Hello, my name is Britnee Wilcox and I am a DNP student at Maryville University. The title of my project is Effectiveness of Comfort B Sedation Assessment in Improving Patient Outcomes in Pediatric Intensive Care Patients. My committee consisted of my chair member at Maryville was Dr. Maria Snell. The second reader was a professor at Maryville as well named Dr. Boniface Stegman. And my community member was Dr. Satish Shah. He is one of the Pediatric Intensive Care Unit intensivists at the facility where the project took place. Some background and significance about the project. My PICO question was, in pediatric patients receiving mechanical ventilation in an intensive care unit, does the implementation of the Comfort B scale, as compared to current practices, decrease duration of mechanical ventilation and the length of hospital stay over 5 months? Pediatric sedation has become a standard of care in the intensive care unit. For many years, children 0 to 18 years of age have undergone sedation with various medications for procedures and mechanical ventilation. Valid and standardized assessment guidelines are essential for this vulnerable population. Often, sedation and analgesia medications are not monitored based on best practice guidelines. Currently, there are limited scales to assess all physiological and behavioral elements in pediatric patients receiving sedation. The population in the PICU is complex as patients are of varying ages, sizes, and developmental and behavioral states. Evidence shows the critical link between sedation management and patient outcomes. Inappropriate analgesia and sedation administration can lead to stress and discomfort, addiction, respiratory depression, withdrawal, delirium, lack of mobility, unplanned extubation, prolonged intubation, organ damage, and many more. Balancing sedation and pain is a complex task with fragile boundaries. Pediatric sedation has been shown to present problems with undersedation and oversedation, leading to adverse patient outcomes. Two significant issues with improper sedation are increased days on a mechanical ventilator and an extended hospital stay. The Comfort B scale is used by nursing and providers to evaluate and manage sedation and pain. The goal of this project was to evaluate the Comfort B scale and how it affects the duration of mechanical ventilation and hospitalization. The tool was assessed for validity and reliability and if it could assist in accurately delivering care with sedation and analgesia medications. The overwhelming goal was to help in preventing unwanted patient outcomes. Some more background and significance information is improper sedation can lead to increased days on a ventilator and extended hospital stay. There was a strong correlation between these two variables. A study by Dorfman et al. 2014 found that the Comfort B scale is the only scale that assesses pain, non-pain related discomfort, and sedation analgesia medication administration in intubated pediatric patients. A study done by Ella et al. 2015 found that the use of the scale reduced the duration of ventilation in children by about 20%. Another study by Egbuda and Mason 2021 found that inappropriate and inadequate sedation leads to adverse patient outcomes. Superato et al. 2020 evaluated the adequacy of pediatric sedation and discovered that only 57.6% were appropriately sedated, with 31.8% being oversedated and 10.6% being undersedated. Here is a little synopsis of what the Comfort B scale is. It evaluates the elements of alertness, calmness versus agitation, respiratory response in intubated and non-intubated patients. We only looked at intubated patients for this project. Physical movement, muscle tone, and facial muscles. And as you can see, nursing or providers can score the patients on a scale from 1 to 5 in each category, and then it would give you a sum of the score at the end. It would automatically populate, and then that total number would drive interventions based on increasing sedation, decreasing sedation, and so forth. And with the documentation in the EMRs at the facility, it gave this exact breakdown to help nurses know how to accurately score the patients. For the review of literature, after an extensive review of literature was done, 3 main themes were consistent with the Comfort B scale. The first theme was impact of prolonged sedation and mechanical ventilation. Multiple studies found that longer duration of days sedated placed patients at a greater risk of being on a ventilator for more time. It was also found that extended time on a ventilator increases the days that they receive pharmacological sedatives, obviously, but with increased days of sedatives, that poses more problems and risks and negative outcomes. The second theme was sedation and pain management during mechanical ventilation. Multiple studies found that the Comfort B scale has shown reliability and validity as an age-appropriate sedation management tool in the pediatric setting. The final theme is improving patient outcomes. Several studies found that using the Comfort B did decrease the total length of stay in the hospital and days that they were admitted to the PICU. It was also found that when using the Comfort B scale, more patients were in the optimally sedated range. The theoretical framework used in this study was Lewin's theory of change. There are 3 phases: unfreeze, moving, and refreezing. The unfreeze phase aligns with this project in that pediatric sedation management needed further development at the facility where the project took place. We wanted to unfreeze the problem by evaluating the Comfort B tool and its impact that it could have on patient outcomes. The moving phase consisted of engaging and encouraging staff with educational handouts and discussion of individualized sedation goals in daily rounds. There were handouts provided at the nurse's station on specific education on how to use the Comfort B scale and when to use it, and then the researcher also provided their assistance whenever needed to answer questions or deliver further education. The refreeze phase was to disseminate the findings and evaluate the impact it made on patient outcomes, and then refreeze the practice changes where they were needed based on the results of the project. Methods and design. For this project, it was quality improvement in nature, where a retrospective chart review was completed on the qualifying electronic medical records. A specific data collection sheet was created for the purpose of the project. This recorded pre- and post-intervention data. All data that was recorded was de-identified and it was quantitative data. There were no patient identifiers and just simply numerical values for what the Comfort B scale was, the length of ventilation, the length of hospitalization, and so forth. The setting of the project was a pediatric intensive care unit located in the Midwest region of the United States. The facility chose to implement the Comfort B scale in September of 2023. The participants for the project were electronic medical records of patients aged 0 to 18 that were not on end-of-life care who were mechanically ventilated. The pre-intervention group consisted of patients admitted from September 2022 to March 2023, and then the post-intervention group were patients admitted September 2023 to March 2024, where the Comfort B scale was documented on. In this project, descriptive statistics were utilized to identify gender and age in the pre- and post-intervention groups. Here is a pie charts of what the sample looked like for the pre- and post-intervention groups. The sample in total was 64% male, which was 16 patients, and 36% female, which was 9 patients. The age ranges were also collected and displayed, and it showed that 52%, which was 13 patients, were under 2 years old. 20%, which was 5 patients, were ages 2 to 6. 4%, which was 1 patient, was aged 6 to 10. 0% were ages 10 to 14, and 24%, which was 6 patients, were aged 14 to 18. The pie charts break down the differences between the pre- and post-intervention groups. As you can see, gender was very consistent in both groups, with male being about 2/3 and female being about 1/3 of the group. And however, age did vary somewhat between the pre- and post sample groups. For the data analysis, a Mann-Whitney U test was chosen as the number of days hospitalized could not be zero. Therefore, since it could not be zero, we would not have a normal distribution. Another reason that the Mann-Whitney U test was chosen is that a small sample size was estimated and a small sample size was yielded. This test was used to signify the difference in length of ventilation and length of hospitalization between the pre and post intervention groups. Descriptive statistics are also important when collecting the quantitative data, as they assisted the researcher in describing and grouping the data to synthesize and evaluate trends. Gender and age were identified as variables that may have impacted the trends in the results that were gathered. Here are the results of the project displayed by box and whisker graphs. The first graphic is showing the pre and post results for the length of hospitalization, and the second graph shows the pre and post data for the length of ventilation. As you can see, the length of time actually increased with both variables in the post-implementation groups. This is represented by the red shaded area. The length of each of these variables was evaluated by number of days. The time of mechanical intubation to the time of mechanical extubation was recorded for length of ventilation, and then the number of days from admission to discharge was recorded for the length of hospitalization. The Mann-Whitney U test concluded that there was no statistical significance between the pre and post implementation of the Comfort B score in length of ventilation or length of hospitalization, as the p-value was greater than 0.05 for both of the variables that were evaluated. There were some limitations to this study that impacted the results, as there are with any research project. The main limitation was the low patient census during the post-implementation phase that yielded a small sample size. This limited the accuracy of assessing the impact that the Comfort B scale had. The small sample also affected the generalizability, as valid conclusions could not be drawn on a larger scale. During the project, there was also some resistance to change by bedside nurses. Some of the electronic medical records were excluded because the Comfort B scale was never documented on. These patients would have otherwise been in the inclusion criteria if this would have been documented on, so that was a limitation. Once this was recognized, however, increased education was provided so that accurate results could be obtained going further. Discussion on the project. The main strength of this project was the heightened attention to pediatric sedation management. Prior to this study, the generalized assessment tool called the SBS scale was used to manage sedation and analgesia medications. This scale is not pediatric specific, and it is a tool that is used in the adult and pediatric settings. Although no statistical significance was found when using the Comfort B, extended education was delivered and received by nursing staff, which likely has impacted the attention and detail of assessments regarding the level of sedation. The Comfort B scale has allowed bedside nursing staff to assess pediatric-specific elements that contribute to the comfort and safety of children. The overwhelming goal is to deliver safe and effective care and to positively impact patient outcomes. Another strength of the study was improved communication among the pediatric intensive care unit team. During the project, nurse manager, nurses, the pediatric intensivist, pharmacist, the maternal child director, the maternal child quality improvement coordinator, and so on were involved in this project. The implementation of the Comfort B scale affected how often sedation management goals were addressed. Since the project increased attention on sedation management, communication on goals, interventions, and daily actions were frequently discussed. Effective interdisciplinary communication is known to be a top contributor to high-quality care. Education among the PICU team was widened with the knowledge and skills of using the Comfort B scale. Now for implications for practice, this affects practice, patients, and the healthcare community. Practice was improved as heightened attention and focus was placed on nursing assessments due to the use of the Comfort B scale. The goal is to have standardized care models so that consistent and high quality care can be delivered. Patients were also impacted with practice changes as the goal is to optimize their physical and mental care. As clinicians, we always aim to reduce adverse outcomes. This project helped to highlight areas of need and what can be done going further to produce positive patient outcomes. The continuum of effects from inadequate sedation affects not only patients and their families, but also the organization as a whole. Medical interventions associated with adverse effects of sedation add to the economic burden. Treatment for adverse effects such as withdrawal, delirium, respiratory depression, muscle atrophy, and skin conditions extends hospital admission, increases medication administration, lengthens the use of medical equipment and supplies, and general inpatient needs. Reducing the duration of mechanical ventilation days has a sizable financial impact on individuals and the organization. Another benefit to the community is that we want to be proactive versus reactive. Being able to identify where the need is before negative outcomes occur would make a sizable impact on the community. And then obviously the goal is to analyze patient outcomes better. So this project allowed nursing to gather those skills and hopefully be able to produce positive effects going further. In conclusion, sedation management in pediatric patients is a critical element in patient outcomes. Without accurate assessments, goals, and care, adverse effects can occur. Improved management with a pediatric-specific approach is crucial to preventing unwanted outcomes. Although this quality improvement project did not have statistical significance, it has shown the importance of educating and practicing high-quality pediatric care pertaining to levels of sedation. Improved communication and heightened attention to sedation management did occur and will continue to influence practice. The study's findings demonstrated that further evaluation of the Comfort B scale is needed to draw accurate conclusions. It is recommended that future studies be conducted to enhance and validate the necessity for pediatric-specific sedation management. In the future, more sedation training and education would be provided to nurses to increase the use of the Comfort B scale during the project. If possible, an extended time frame would also be utilized to gather a larger sample size to support recommendations and further conclusions. Completing this D&P project impacted myself in many ways. I have gained growth and development with interprofessional collaboration, communication, managing barriers and setbacks, research skills, and much more. I will be able to carry this education and skills with me in future occupational opportunities and patient care. This has prepared me to work better in team settings. The learning I have gained from this project will qualify me for extended job opportunities and allow me to contribute to research at my future workplaces. The acquired strengths and resilience with barriers to complete the D&P project has taught me a lot about myself and given me confidence professionally going forward. Here is a slide with some of my references. And then one more slide. Thank you very much for listening, and please feel free to reach out with any questions. Thanks.